Good evening, friends. OrthoTV is on. Poonam, are you on OrthoTV? Okay, fine. All right. So, good evening, friends. I am Dr. Depak Dave.
Recording in progress.
Along with my colleague, Dr. Dhanasekara Raja from Ganga Hospital, Coimbatore. We are the education committee members for the Indian Society for Hip and Knee Surgeons. We had our last teaching program in March. After that, we had our conference in Kolkata in April. And then we were waiting for the new fellows and colleagues to join. So for the second session, this is the first academic program we are having. And just like last year, we will be getting the all very senior, stalwart people, experts in the field to present their work. I will encourage all of you to pass on this message to all your friends or colleagues. This is a free lecture program and very useful. Last year, we had a very successful program where most of the Indian stalwart faculties, they participated on our request. So on behalf of our managing trustee, Dr. Vikram Shah, our president, Dr. Indrajit Sardar, the members of the trust board, and myself and Dr. Dhanasekara Raja as education committee, let me first thank Dr. Parag Sancheti and Dr. J.V. Srinivasan, both senior people. Dr. Dhanasekara Raja will introduce them, but they've agreed to come and start the talk of this session. Couple of things which I would like to mention to you. The next Ishks conference, the announcement is going to Parag Sancheti by Monday. It's on the 4th, 5th, 6th April in Mumbai. So all the young surgeons are encouraged to participate, present their work, papers. You will hear the news very soon. That's the first thing I would like to tell. And second thing, as I said, is very important. All of you who are doing the joint replacements, please try to be a member of Ishks and also participate in the joint registry. The Indian Society's joint registry has been doing good data collecting, and I encourage all the young surgeons to join the Ishks as a member. There are lots of benefits, not only to get the platform, but the fellowship, one-to-one interactions with the senior consultants. So with this introduction, I would request my colleague, Dr. Dhanasekara Raja, to introduce the first speaker. Dhana.
Okay, good evening, everybody. Welcome to the Ishks teaching program. I invite our president, past president Ishks, and President Dr. Indrajit Sardar. Indrajit from Kolkata.
Yeah, good evening.
So we are going to have two lectures today, one on knee replacement, one on hip replacement. The first lecture is going to be delivered by Dr. Parag Sancheti. He is the director of the Sancheti Orthopaedic Institute of Pune. It doesn't require introduction. He was the past president of APAS and past president of Maharashtra Orthopaedic Association. He is going to give a lecture on principles of correcting a varus deformity and reconstruction of bone defect. Next, we have excellent speaker, Dr. J.V. Srinivasan from Bengaluru. He's a consultant lead orthopedic surgeon at Trustee Medical Center in Bengaluru. So thank you for joining Dr. Parag and Dr. Srinivas. We'll go on to the lectures. And this time we have a lot of new fellowship programs running. There are almost 50 fellowship arthroplasty F&B seats in India. So I urge the lead consultants of each institute to share this program with their fellows and make it mandatory for them to join. It's a very useful program, and we have excellent lectures and will be very beneficial for them. So with this introduction, I invite Dr. Parag to start the presentation. The audio is muted, sir.
Good evening, everybody. On the outset, I would like to thank the Ishks Organizing Committee and the Executive Committee for inviting me, especially Dr. Dhanasekara Raja, Dr. Deepak Dave, President Dr. Indrajit Sarkar, and all others. It's a great pleasure to be on this platform, which is a new innings again after the new President Dr. Sardar has taken over. So it's my privilege to be on this platform. My take today is going to be to speak to you about TKR in varus deformity. That is what all of us see every day, and in my practice at least, 90% of the cases I do are varus. I hope you can hear me well and see my screen.
Yes.
Perfect. So I'm going to speak more about doing TKR in a conventional setup, of course, with the advent of robotic and navigation and all those things. The way we tackle varus deformity has drastically changed. But since the majority of the viewers would probably be interested in how to treat a conventional way, I'm going to speak on that. Whenever we see varus deformities, I think the first thing we need to identify is whether this deformity is correctable or a fixed deformity, because that is going to decide what kind of release you're going to require to be doing. And if there is also an extraarticular deformity, we need to take the long leg x-rays and find that out. One thing I find important in this severe varus deformity is to do a valgus stress view. As you can see, this is a single joint weight bearing on your left. And once you do a valgus stress view, that deformity actually corrects out, and you can then see the bone defect. And then here you can realize that not much medial release is going to be required. So that's the value of doing a valgus stress view, as opposed to this case where when you do give a valgus stress, the deformity is hardly correcting. That shows that the medial structures are more contracted, and then this is the case where you're probably going to require more amount of release. We all know that the medial structures which are contracted are the deep MCL, the posteromedial capsule, the semimembranosus, pes, and cineris, and these are the generally contracted structures. But whenever we are dealing with the severe varus deformities, we also get contracture of the superficial MCL, the posterior oblique ligamenti, and the joint capsule too. And then in severe deformities, when there is a subluxation, we get the medial bone defects also. In fixed varus deformity, one should note that in tightness, wherever there is tightness of the middle and the anterior part of the deep MCL, then the deformity is more in flexion. And the persistent varus deformity in extension, you have the tightness of the posterior portion of the deep MCL and occasionally SMCL. And therefore, we have to release accordingly depending on where the tightness is. The medial release is very important in the severe varus deformities, and what happens by the time you do the extensive medial release, the soft tissue capsule of the medial sleeve gets retracted and you're unable to close the wound well, and you get leaking wounds the next day. So what I've started doing is, whenever I'm doing the dissection, I kind of take a vehicle number 2 stitch and keep on tagging the medial structures, which include the capsule, the deep MCL, and all the way posteromedially. And so when I close, I'm able to get a good closure. So this is an important tip for people dealing with severe varus deformity, so as to get a watertight closure. Otherwise, second or third day, you will find that whenever you do extensive release, the wounds are leaking. I think balancing is the key, and wherever you are balancing either a valgus deformity or a varus deformity, in extension, once you've done the releases required, you should have a 2 to 3 millimeter giving way on either side, which will indicate that the knee is balanced in extension. Whenever we are dealing with severe deformities, I would like to share my 3 tricks which I do to get these severe deformities corrected. One is the release of the posteromedial structure, and I'll just show you in a minute how do I do it, the pie crusting. And the last structure I release is the superficial MCL, and nowadays I would say that it's very rare that I would be releasing the superficial MCL. So how do I do release of the posteromedial capsule? I give a figure of 4 position, as you can see here in the zoomed out view, and in here we externally rotate the tibia, and then the posteromedial part of the capsule comes into view. We use a cautery close to the bone, and then that is how the release is completely done. This way we are able to reach the posteromedial part, stay close to the bone so that there is no damage to the neurovascular structure, and then we get a complete release of the posteromedial structures in severe varus deformities. Another thing which I do is the pie crusting of the MCL. I use the 11 blade or a 16 needle which will help to do the pie crusting, not more than 8 or 9 bites. That is important. The last step, which I nowadays very rarely required to do, is the release of the superficial MCL. As we know, the superficial MCL is attached about 6.5 centimeters below the tibial joint line, so you can release it all the way till then. The important thing while releasing the superficial MCL is don't let it blow out, otherwise then you've got to move to a constant prosthesis. Be very careful while releasing the superficial MCL. So these are the 3 tricks which I have in my armamentarium when I'm dealing with severe varus deformities. Coming to the second part of my talk, I will be speaking about the bone defects. I think the reconstruction of bone defects is very important. Like in a valgus knee, you will get defect on the lateral tibial condyle or the femoral condyle. In the varus deformities, you will see the medial side which is showing the defects. And you may have the defects classified as contained, which are easy to tackle, peripheral defects which you see, and a composite defect. And then we also classify as per the size of the defect. The smaller ones are less than 5 millimeters, medium sized defects are about 5 to 9 millimeters, and the large defects are greater than 9 millimeters. And each of these defects, once you have noticed the size, require a different management strategy. If the size is less than, let's say 5 millimeters, then what we need to do is just do a little bit increase in the tibial cut. People might object to this, but theoretically it's not a right thing, but practically it doesn't matter 1 or 2 millimeters, because when we cut 1 or 2 millimeters of the tibia, it is going to affect the flexion and extension space equally. So you need not worry, and you can compensate that by a thickness of the poly where you'll get a balanced knee. And then we undersize the tibial component so that the extra defect which is in extra bone, that can be cut off. And then we reduce the tenting of the medial side as well as the bone defect is reduced. So that is for smaller defect, you can do that. Again, if it is a content defect, I told you can just be filled with bone grafts, and these are the easier ones to tackle. If the defect is more than 5 to 9 millimeters, then what you do is you can put screws along with the cement, and then you can fill up the bone defect very well. Here you may decide whether you want to add a stem or not a stem. This is optional depending on what is the extent of the defect. If the defect is more than 9 millimeters, these are the difficult ones, and here we have to make sure that we reconstruct the defect very well. Here we have to use the bone grafts, which may be allograft if you have access to them, or the autografts also from the proximal end of the tibia or the distal femur, what you have cut. You can keep them and use them as bone graft. Wedges can be used, or then use a custom-made component. Whether to add a stem extension or not is a decision you take on table, and I'll talk to you about the criteria for adding the stem extension. I think it is very important that if it is a large defect, more often than not, you should err on the side of adding a stem, because I think that will help in many ways, and I will speak about that in a minute. So when there is a large defect, what we do is this technique described by my father. It is called as the KHS rectangular graft technique, where we make a slot, put in a graft which is created from the cut of the proximal tibia or the distal femur, and pack it in, and then put a screw to it. Let's take an example. This was a severe varus deformity. We can see the bone defect, and the bone defect becomes more visualized when you do the valgus stress X-ray. After exposure, you can see the defect which is seen of the medial tibial plateau. Then we identify the size. This is more than 9 millimeters, so we are going to require the reconstruction. We do the rectangular slot technique, which is done with a rectangular graft, which is put in this rectangular slot. And then are you able to hear me?
There's a lot of echo, sir. Any other system it's locked near?
No, not near me.
Lot of echo happening. Echo.
Yeah, that's what I was.
A lot of echo sound coming. Correct.
But now it's not coming.
Oh, it's not.
No.
Yes, sir.
Okay, so let me continue. It just started coming, or you want me to go back a few slides?
No, only this slide, sir. Okay.
Okay, perfect. So I think I was just talking to you about, you measure the size of the defect. You can see this is more than 9 millimeters. So we are going to reconstruct this. And what was described by my father, KHS technique, what we call it, make a rectangular slot and then you kind of put a graft with the press fit technique and then fix with the screw. This works very well and initiates the new bone formation. And you can see here it is fixed with the screws and then the whole defect of nearly 12 millimeters is reconstructed very well. This is a post-op X-ray of the same patient. And as long as you got your alignment right, I think these do heal well. And I'm a person who believe in the strategy of, a mechanical alignment. Definitely till date I haven't changed, but tomorrow I don't know. Coming to the metal wedges this is something I rarely use because they're quite expensive. The cost of each wedge may be about 10 to 15,000 rupees or more. And then we have to also sometimes cut little more bone to put these wedges. So my threshold to use this is very high. But they are now available. We are also getting these tantalum metal wedges which have a greater affinity for bone and get incorporated very easily. So this was an example where we had a deformity or a bone loss of more than 12 millimeters. We used a small wedge here, you can see, and that wedge was punched inside and it healed really well.
I think we need to mute everybody except the speaker.
So adding constraint is something very important. And as I was telling you, if the defect on the side of the condyle, which the defect is the medial or lateral, if it is greater than 30%, then I would not hesitate to add a stem because it offloads the defect. It helps in not toggling of the tibial component and prevents loosening. I think this is the reason why we should always add a stem. And again, my threshold to add a stem whenever there is a bone defect is very low. Sometimes I use a shorter stem, about 30 millimeters, or sometimes I use a longer one, about 100 millimeters. And sometimes they are short stubby stems which are fully cemented. The longer ones I use only hybrid kind of cementing in the metaphyseal area. So this is another patient, severe varus deformity. You can see, patient is hardly able to walk. There is a pathological fracture which is also seen on the left side, and this is a stress fracture. Again, you see the bone defect which is there. We reconstructed it with a rectangular technique on both the sides. The graft is punched in and then fixed with a screw, as you can see here. This is the final X-ray. So this is a great technique to follow and we use it all the time. This is the same patient 2 years later, walking well. So I think this kind of reconstruction techniques are easy to follow and one should use them. It will just suffice to say that less than 5 millimeters just cement is enough. 5 to 9 millimeters cement with screws, and more than 9 millimeters you can reconstruct the graft, or then you can use a metal wedge. So the carry-home message is that whenever you're dealing with severe varus deformities, what is important is don't do the release all the way on the first go. Do a gradual release, do a release which will not give way on the medial side and make you add constraint. With the increased knowledge of robotics and talking about the various alignments, I would like to say that what I have learned from these people is that the amount of release which I require now is low, and I don't hesitate to actually leave the varus deformity a little bit in varus. I don't completely correct them to neutral, and I really don't go all the way. That's a small change which I must accept I have made, and this is something called as the adjusted mechanical alignment is what I believe in the present moment. Definitely a PS design in severe varus deformities is the way to go. Very few experienced surgeons should use the CR. Otherwise, PS is good because the integrity of the PCL really don't know. And I would be very wary of using a cruciate retaining knee. The bone defects, if they are present, you will come to know about them in the valgus stress view, plan for them, and definitely keep a backup of constraint processes ready when you're dealing with severe varus deformities. And of course, the long stem should also be kept ready. And my threshold to use a long stem in bone defects is very low. I don't hesitate to use them. As I just told you, the short stubby stems which are fully cemented, or the long ones which are hybrid cemented only in the metaphyseal area. So this is how to tackle the severe varus deformities. And once again, I would like to thank President Dr. Sardar, Secretary Dr. Leo, Dr. Deepak Dave, Dr. Dhanasekara, and of course the trustees Vikram, Shah and Pachore sir for this opportunity. Thank you very much.
Yeah. Thanks, Dr. Parag. We just request delegates to put some questions, whatever they have in the chat box. Before we move on to the next lecture, we have some time. And by the time we get some questions on the chat box, Parag, I have a couple of need some guidance from you.
Sure, sir. I don't know whether to guide you, but I'll try my best.
No. Any specific requirement, whether you use SS screw or titanium screw, will it matter?
Whenever possible, I would try to use a titanium screw, but it does not matter at all. Stainless steel is much cheaper, and I'm happy to use a stainless steel screw as well. So it doesn't really.
And do we make sure that it doesn't touch the base plate?
Definitely, that's a great point. I would leave them 2 millimeters short so that I get a cement mantle between the head of the screw and the base plate. I think that is very important, because otherwise, if the metal base plate, the undersurface, is coming in contact with the screw, then there is going to be a corrosive wear. So I would definitely avoid that.
Yeah. My second point, I have heard you in the past, but just for the knowledge of the young friends, those who have joined, there is one condition. Usually you just showed beautifully that you put figure of 4 and do the lot of medial and posteromedial release for the varus. But we do some lateral release of popliteus in some rare condition in varus deformity also. Can you just put a light on that?
Yes, that's a great point, and I did not mention it, but I'm glad you brought it out. Whenever there is a subluxated knee, and patient has kind of a varus thrust while walking, these are the patients, I would do a guarded popliteus tendon release. The reason why is, if you see the attachment of the popliteus, it's not only on the lateral side, it goes slightly on the medial side, on the femoral side, and has an attachment on the medial side of the femoral condyle as well. And therefore, doing a partial guarded release in subluxated knees with a varus thrust, it definitely helps to balance the knee, and that is the last bit which is required in these patients. So that's a great point, Dave sir, and I do that in some of the cases with subluxation.
Yeah. My another question to you is, you mentioned about the short cemented rods.
Yes.
Now, apart from the varus, do you, of course, it is not related to this, but as you already brought that point, do you use this in obese patients also?
The answer is yes, I do. I have had a debate on this with many, and I would be happy to hear the faculty and Srinivasan as well. JV can tell whether he uses in the obese patient, but I do use it. I think it because we always have the fear of early loosening in patients with obesity, and I particularly use it for proper weight transmission. And in these are the patients, I would not use a long stem. I use a short stubby stem which is fully cemented, and I feel biomechanically the construct is better in these obese patients who have a higher load on their implant as compared to a patient with a BMI less than 30. JV, you have
Dr.
anything?
Raja, Dhanasekara, and
Yes,
Dr. Srinivasan, your comments also, please.
We are also started using regularly the short stubby stem, which Dr. Parag is telling. In an obese patient, whenever the BMI is more than 35, we are sure that we explain the patient that it requires a stem, and we do it, sir. Whenever it is beyond 35, always we use a stem on the tibial side.
Dhana?
Yes, sir. Same indication, but if the component size is very small, it is somebody has a bone stock and the cortex is supporting. Because one of the papers from Australian registry has shown that when patients with high BMI where they use them, the loosening rate is high.
Right.
So we're not sure. There is no consensus. We did the obesity consensus. There was no consensus out of it. So based on individual case-to-case basis, we decide.
Right. I think that's a fair way to do it. I think somebody has two devices on. That is why this is echoing. I don't know who, but anyway.
Dr. Parag,
Ramesh, can you look into this technical part?
Okay. Yes, JV.
Parag, you very nicely explained the soft tissue release on the medial side for a varus knee. For a mild deformity, do you still use pie crusting of the MCL? Anytime your experience on that?
No, so that will be as the last step. I have moved away, to be honest, from pie crusting now. It's a little dangerous sometimes if you do too much of bites or too much of pie crusting, more than 10 or 11 dips, then you are at a fear of making the MCL incompetent. So I have moved away from it, and it's a little bit of a last step in my armamentarium to balance a varus knee.
Parag,
Yes.
one question.
Sir.
The one question is that what is the nature of the tibial wings that you use? Are they straight or are they inclined backwards?
So you mean the keel?
The keel.
So I think that is again a component specific thing. Most of the times the wings are going backwards, and we don't have any control on that because the companies which I use are mainly next gen Zimmer. They have the wings going backwards, and I use the Max Merrill implant, similar. So I have no experience with the keel, probably the wings going forward. I would be happy if anybody has any experience.
So what is you said you will use adjusted mechanical
Yes.
alignment if the gross varus.
Yes.
So using a rope system, what is the alignment you follow?
So I use the robo not very often, but then I would have my outer limit is 3 degrees. I would not go beyond the 3-degree boundary for balancing or taking the cut. So I will go up to 3 degrees, and that's what I would say is the adjusted mechanical axis. And in those cases, I would use the robo. But what I'm also doing is, in the end, when you're balancing it, and that the opening is still slightly more on the lateral side and a couple of millimeters less on the medial side, I just go ahead and with a free hand, I cut a couple of millimeters more on the medial side, and then you put the poly, the knee is balanced. So, that is a crude way of the adjusted mechanical alignment for me.
Parag, your routine practice of doing a long leg x-rays or weight-bearing scanograms?
Yes, I have started doing scanograms in all the patients. I think it's just a habit because we have residents then who draw all the angles in the morning meeting which we present. If you ask me it's necessary or not, I would say it's not mandatory, but as a routine protocol, we are doing single joint weight bearing X-ray AP and a scanogram in all the patients. If you want to be selective, but then patients in whom you see there is too much of bowing and you can see those patients, they have a typical waddling gait, you should do it. Number two, if the patient has any previous history of fracture femur or a tibia where you are suspecting some malunion, you should do it. Or if the patient sometimes has an unexplained pain, he has a deformity, but he says in the last 2 or 3 weeks it's more often now that on a long leg X-ray you will find a stress fracture. So these are the indications where you should do it, but otherwise, you may get away with a standard AP lateral radiograph.
One question.
Okay.
Yes, Dana.
So, when do you use a constraint process? What is the indication when you need to switch over to a constraint process from a PS?
Yeah, so that's a great question. In a severe varus deformity, if I do find that my ligaments are not competent, the medial side is slightly giving way, and if I over release sometimes, then I would move to a constraint processes. If sometimes the MCL is incompetent, you can make that out, especially in severe deformities, or in more so in valgus deformities. We find that, then that's very difficult to balance. Then these are the patients in whom I would use a constraint prosthesis.
How much lateral laxity would you accept? Because if it's very tight medially, do you find sometimes that there is some lateral laxity?
I would not accept it, So in the end, I would like to have a well-balanced knee, about a couple of millimeters opening on both the sides. So if that does happen, as I said, then I don't hesitate to do a little bit more cut, because more often than not, you will find that the openings on the lateral side in a varus knee, the medial side is tight. So just increase the cut a little bit and then it balances out. But I would not leave any knee which is opening less on the medial side and more on the lateral side. So for that, I have a very low threshold. For me, a well-balanced knee is more important than a well-aligned knee. I don't really worry about that, because since if I'm doing non-robotic, anyway, I don't have any control over that. Great.
Okay.
Thank you.
I think that's probably we can switch on to the next speaker once again. Dr. Parag, on behalf of my... Yes, Dhanasekara.
Questions in the chat box.
Okay.
Yeah.
So Dr. Avinash Dev has asked, hi sir, I want to ask if you get pre-op valgus stress view for all your OA varus knees or in selected cases only?
No, so not in all cases. Whenever I see there is a deformity more than 15 degrees, I would do a valgus stress X-ray. If, I do feel that there is a varus thrust, while walking you can make out these patients, they have that typical gait with a varus thrust, I would do a valgus stress X-ray. And wherever then I want to see that bone defect well, where I'm planning a reconstruction of the bone defect, I would do a valgus stress X-ray.
Okay,
Parag, can you see the chat? There are two other questions also. Can you see yourself?
I'll just open it up.
Q&A.
Yes, so the second question is, when deformity is between 5 to 9 millimeters, is it screws first, cement later, or cement first followed by screws? So always screws first. Always screws first. And once you put the screws, then you cement it. Because if you do the other way around, it will be very difficult for you to drill through the cement mantle and put the screws. So I would always put the screws first and then the cement mantle. How much will the ultra-congruent insert be useful in CR knees with severe varus? So I think that's a great question, and it opens a complete new discussion. Whether if you want to do preserve the cruciate PCL, or whether you want to avoid the box cut, then in a severe varus deformity, are you going to be better off by ultra-congruent insert, or nowadays we are using the anterior lipped congruent insert? I think the answer to that is yes. We might be able to then avoid the box cut and use this constrained kind of ultra congruent polys. And I don't have any particular experience, because for me, I'm a PS surgeon, and I haven't yet moved to retaining the box or the PCL. I'm 100% PS as of now. Again, tomorrow I don't know, but that is why I don't have much experience. All my inserts are, PS polys.
So can I add a few more points?
Yes, please.
The varus deformity, the deformity is in the mediolateral plane. The ultra-congruent is useful in stabilizing knee in the AP plane. So your primary aim is to balance the knee in the mediolateral plane. For that, the ultra-congruent is not going to help you. So I have revised some patients where they used a deep dish insert without balancing in the coronal plane, and they have failed very early. So ultra-congruent is not going to be useful in balancing your varus knees. You have to do a soft tissue release and balance that.
Perfect. I think that's the right answer. Yeah. Okay, I think there are no more questions I see on the chat box. So thank you again. Thank you, Dhanasekara, sir.
Yeah, fine. Thank you. By the time Dr. J.V. Srinivasan starts sharing his screen, thank you, Parag, on behalf of all of us at the team Ishks, and we'll catch you later on for the next round. Dr. J.V., can you just start sharing your screen? I just want to remind you once again, the next academic session is on the 14th of September, and we will be having two similar stalwart senior people talking. Please convey this message to your friends and colleagues. And as I said, the 3 points, the next Mumbai meeting is 4, 5, 6 April. Please be member of Ishks. There are lots of benefits for the young surgeons, and please try to contribute to the registry. Whatever joint you are doing, it will certainly be important. It's very safe. Nobody knows about your volume or anything. It's only up to you, but you will be able to contribute the great data of the registry. So with these points, Dr. J.V. Srinivasan, thank you on behalf of me and Dr. Dhanasekara and our team, Dr. Indrajit Sardar, for accepting the invitation. He's a senior surgeon at Bangalore, trained in AIMS, and been practicing in Bangalore since 25 years. And coming up with a very important topic, very difficult cases of dysplastic hip. JV, please start your talk.
Thank you, sir. Thanks for the invitation. First of all, I want to thank Ishks Scientific Session, Dr. Dipak sir and Dr. Dhanasekara for invitation, and also Ishks President, Dr. Sarkar sir, for giving an opportunity, and the President sir and all the members of the Ishks for giving an opportunity to have a presentation. Today, I will be talking on total hip replacement on a dysplastic hip. I'm sure most of the surgeons are doing a hip surgeries or hip replacement. They all start with a fracture neck femur, hemiorthoplasties, and they progress to a total hip orthoplasty. But dysplastic hip is a different ball game. It's not like a regular total hip replacement. So I thought I'll present it in 3 parts. One is pathoanatomy and the planning for the surgery in a dysplastic hip. Second part will be a short video of subtrochanteric shortening. That is a very important technique which people have to learn when they're doing a hip replacement in a dysplastic hip, especially CRO 3 and CRO 4. And lastly, I'll show some of the cases how we have executed the same technique and same planning, what I'm going to talk, how we have executed in some of the cases. I'll be showing. This is the 3 parts of my presentation. And later we can have a discussion on it, definitely. So we all have seen, okay, slides moving. Yeah, okay. Okay, hip dysplasia is a disorder of abnormal development and or a dislocation hip secondary to the capsule laxity. We all have seen in a pediatric cases dislocated hips, and we have reduced it and put it a plaster cast and all. But usually these patients come for hip replacement in 2 situations. One, dysplasia was previously treated by some kind of surgical intervention, either on the acetabular side or the femoral side. They come to us in adolescence or the adulthood for the surgery, or a dysplasia which is not been treated and ignored for quite some time. And when the child is at marriageable age, especially girls or the adults, when they want to get into an active life, they come to us for a surgery which is not been treated. So these 2 are the 2 spectrums of patients with a dysplastic hip coming for us with for the hip replacement. If you see the pathoanatomy, the acetabular excessive anteversion is one of the main finding on the acetabular side, and the femur excessive anteversion. Normal routine anteversion is 15 to 20 degrees, which we all do in a routine hip surgery. Whereas in the dysplastic hip, excessive femoral anteversion is one of the anatomical finding when we go in for a surgery, and we should always remember this excessive anteversion when we plan for the surgery. If you see epidemiology, almost 1/3 of all the cases which are coming to us with hip osteoarthritis are usually because of the early dysplastic hip or a very mild dysplastic hip. We all follow Crow's classification. I'm sure most of you know it. In that, we have type 3, 4 types, 1, 2, 3, 4. As far as the proximal displacement is concerned, type 1 is less than 10% displacement of the femoral head displacement. And type 2 is between 10 to 15%. Type 3 is 15 to 20%. Type 4 is greater than 20%. As far as femoral head subluxation, if you see in all these types, less than 50% is type 1. Type 2 is between 50 to 75%. Type 3 is between 70 to 100%. That means the femoral head subluxation is there, almost 75 to 100% subluxation, but still in contact with your primary acetabulum. Whereas type 4 is 100% subluxation. Your femoral head will be, say, way above articulating with the ilium. This is the type 4. Type 3 and 4 is a real challenging situation to do a hip replacement. It is not like a routine hip surgery. So if you see the pictorial classification, this is type 1 and type 2 images. Type 1 is less than 50% femoral head displacement. Type 2 is between 50 to 75%. If you see, this is a classical X-rays what we get. Usually we think it's an osteoarthritis, but definitely this is a dysplastic hip, which has been having dysplasia, mild form of dysplasia from the childhood, and they come to us in adulthood for the hip replacement surgery. You should remember always this is one of the main cause for patient to have a idiopathic arthritis. Type 2, as I said, a 50 to 75% displacement of the femoral head. If you see the acetabulum, it is shallow and excessively anteverted. Femur also excessively anteverted, and the displacement of the femoral head is there. Type 3 and 4 is the most challenging situation. Unless you are experienced and you are trained for doing this, you should not venture into a hip replacement on a type 3 and 4, or use the help of a senior colleague whenever you are executing a surgery on a patient with CRO 3 and CRO 4. Here the femoral head displacement is more than 75%. In type 4, it is almost 100%. It usually has a pseudoacetabulum as well. So in these cases, trying to do a surgery like a routine surgery and you think you can reduce the hip, first of all, getting a acetabulum into an anatomical location or the natural position and preparing the femur and bringing back to the anatomical position is a challenging situation unless you are trained with subtrochanteric shortening osteotomy. And if you don't know that technique, don't venture into a THR in a type 3 and type CRO 3 and CRO 4. So classic example of CRO 3, it is almost 4, and CRO 4 where the femoral head is completely articulating with the ilium and forming a pseudoacetabulum. This is a classical classification of dysplastic hip CRO 1, 2, 3, 4. And there's another classification which is not much of use for the planning. If you see the anatomical defects in the dysplastic hip, as far as the acetabulum is concerned, it usually is a shallow acetabulum and it is sloping acetabulum. You don't have a depth on it. There is a deficient bone support on supralaterally. Remember that supralateral bone support will be not there whenever you prepare an acetabulum. When you ream supralaterally, the support is not there. You should be prepared. Initially, when we started surgery, we used to have bone grafts. Now we have a trabecular metal augments to support supralaterally. And the decrease AP dimension. In these cases, you start reaming and trying to put a cup which has supra-inferior capture. You think that I'll get a good 360-degree capture. You try to ream it. You will ream the anterior wall off. Always remember, in a dysplastic hip, the diameter of the cup is dictated by the AP capture, not supra-inferior. It is only the AP capture. Whatever the size you get in the AP capture, you take it, and defect what you have supralaterally, you need to have a bone graft or a trabecular metal augment. You try to get supra-inferior capture, you will ream the anterior wall off, and then the whole cup is unstable. As I said, posterior wall you have adequate wall, anterior wall is usually thin. Every reamer you use in a dysplastic hip, always feel the anterior and the posterior wall, how much bone is remaining. Then carefully ream the acetabulum. As far as femur is concerned, usually femurs are hypoplastic. The medullary canal will be very, very, very narrow. There will be a valgus neck, and the persistent, as I said, anteversion. Femur anteversion will be excessively anteverted. Normally 15-20 degrees of anteversion we see. And in these cases, it will be excessively anteverted. Be prepared to derotate the proximal fragment, which I'll show you in the subsequent slides. And there will be hypoplasia of the femur. And obviously, if you think that femoral head you will use as a bone graft, you will never get as a femoral head bone graft, because the femoral head will be a small ball there. You cannot use it as a support for your acetabulum reconstruction. As far as soft tissue is concerned in the dysplastic hip, you will have a very, very thick, elongated capsule. This is a classical picture of a dysplastic hip. The muscles are contracted, especially the iliopsoas is contracted, rectus is contracted, adductors are very much contracted. Then you have a shortened sciatic nerve. That's the reason I said you can never pull the CRO 3, CRO 4 down, because the nerve is shortened. You try to reduce the hip joint, then patient will land up with sciatic nerve palsy. And always remember the line of pull of the abductors, that is, would be horizontal. It is not an oblique one. It is a horizontal one. You have to always remember this soft tissue whenever you're planning the surgery. So radiographs, what radiographs we do? Normally, we all do a standard EP and lateral radiograph. In EP radiograph, you can, what are the abnormalities? You can see that decreased sphericity of the femoral head, which I was mentioning, the small head, excessively anteverted, and abnormality in the pelvis. Sometimes there will be, if it's a unilateral dysplasia, there will be a tilting of the pelvis. Always look at it. And that is very, very important to before you plan your surgery. Then certain angles we see. What the most common one is a lateral central edge angle, that angle formed from the central of the femoral head to the vertical and to the edge of the acetabulum. This is the lateral central edge angle. Usually it should be less than 20 degrees. Anything it is less than that, if it goes to negative, that means your femoral head hip dysplasia is there. Femoral head getting displaced and proximally migrated. Then you have a Tony's angle, which again the angle formed by the weight-bearing part of the acetabulum to the horizontal line. It usually should be around 10 degrees. Anything abnormal, you assume that it's a dysplastic hip. Then again, CT scan can be used to assess your structural abnormality on the femoral head, neck, and the acetabulum as well. This is the lateral central edge angle. That's how you calculate on a plain radiograph, and then check the angle. Normal is 20 to 45 degrees. Anything less than 25 is a diagnostic of a dysplastic hip. Then there's a Tony's angle. This is how you calculate your Tony's angle on a plain radiograph to check it is. Normally it should be around 10 degrees. Again, you have a acetabular angle to check the depth of the acetabulum and the angle. Again, this helps to diagnose a dysplastic hip. So principles, 4 main issues in management of these patients. The limb length discrepancy is very important. As I said, CRO 3, CRO 4 patient usually has severe shortening, and they expect that the limb would be of same length after the surgery. You always plan how to lengthen your limb, and don't promise that you will get 100% correction of the limb length in these cases. Then the second point is placement of coverage of the cup. As I was mentioning before, the placement, whether you are going to have it in an anatomical location or you are going to accept a high hip center, or in a pseudo-acetabulum you're going to keep. Normally, we always plan an acetabulum to be the anatomical location than accepting the high hip center. But in rare cases, we have to accept a high hip center. Then in these cases, you need to plan to have a small femoral and acetabular component, because these cases are in the adolescence between 18 to 25 years. The hip is not well developed. You cannot go with a regular implant. The acetabular component should be very small components you should be planning. And the acetabulum femur also, you should have a small component, which I'll tell. And the technique, very important, whether you're going to do an anterolateral approach, direct anterior approach, or posterior approach, it is your choice. But definitely in CRO 3 and 4, I always suggest you to go posteriorly. If you're a posterior surgeon, it's easier. You can feel the sciatic nerve tension, and you can do a subtrochanteric shortening and do a reduction in the hip joint. That makes easier. But definitely some people can do an anterolateral approach if they're trained in it. So exposure, as I said, it's in CRO 1 and CRO 2, it is surgeon's choice. They can do an anterolateral approach or the posterior approach. And you should be ready for doing a trochanteric osteotomy, a trochanteric slide, if you can reduce the hip joint in CRO 3 or 4. If you're not able to reduce, be prepared for a subtrochanteric shortening, osteotomy, and derotating the proximal fragment. And you should plan your implants accordingly. In CRO 3, 4, have an implant which you will get a distal fixation, and allows you to do a subtrochanteric shortening osteotomy. So implant, as I said before, you need to plan a small size cup and liner, that is between 40 to 46. Usually most of the company implants would come between 40, 44, starts with 44. In these cases, be ready with 40, 42, 44. DPO has a small hips, it's a small liners that you have to order it. Then again, you should have a heads, which is 22 millimeter head. You cannot accommodate 28 or 32 head in these cases. And since these patients are young patients, we should have a ceramic on poly. We can plan a ceramic liner and a ceramic head and a poly liner, I mean to say. If you possible ceramic on ceramic, but you don't get in that small size. So poly liner and ceramic head is good enough for these young patients. And on the femur side, you need to have a modular stem. In case if you're doing a subtrochanteric shortening, you need to have a modular stem which has a narrow diameter on the for the distal fixation. So SROM is fantastic instrument or the implant used for Cro 3 and Cro 4 because the smallest diameter is 6 millimeter. If you see, these are the different implants for the dysplastic on the femoral side. SROM, as I said, is a very good implant, which is the smallest diameter of the femoral stem you get, that is 6 millimeter. And you have metaphyseal component, and you have option of rotating your proximal metaphyseal piece to derotate. That is the excessively anteverted proximal femur. You can derotate using the SROM implant. Yes, Exeter cemented stem also, in case if you are doing a cemented one, Exeter smallest stem is there where you can put it in, derotate it and cement the component. Wagner cones can be used if your medullary canal is wide enough. FMT stem was available. I don't know whether it's available now. If you're using a fully coated stem, Echelon stem is also available, which comes in the diameter of 11. If your medullary canal is less than 11, very difficult to use these kind of implants. So surgical principles, you need to restore as far as possible anatomical hip center. As I said, augmentation of postero-superior defect with either a bone graft or a trabecular metal support. Reserve hip high center in case if you're doing a surgery and if a cup, you have put a cup and you don't have enough supralateral support and you don't have an augment, and if you're going to put your entire cup on the graft, then you plan for a high hip center where you have a good bone support for the cup. Unless you don't have a good support only, then you should go to a high hip center. As far as possible, bring the hip joint to anatomical hip center. And an uncemented hemispherical cup with a multi-hole cup which can put multiple screws is an ideal cup in this situation. Never go with cluster hole or a segmental hole where you have only 3 holes. Then you will not have a place to put the screw. Multi-hole cup is a good choice in these cases, small multi-hole cup. And avoid excessive medialization of the cup, because you're trying to get a good capture, you go on reaming. Then you ream the median medullary canal. So you should avoid it. As far as femur is concerned, as I said, you need a prosthesis which has a narrow metaphyseal flare. On the metaphysis, you cannot have a regular metaphyseal loading stem like summit stem or synergy stem, because the metaphyseal flare is very thin. So you need to have a stem which has a very narrow metaphyseal flare. We should be, as I said, be aware with the excessive anteversion. You should be in a position to derotate the proximal fragment. Cemented, uncemented, based on the philosophy, bone quality, age of the patient, and may require shortening osteotomy, as I said before. And these are some of the consideration before you plan. These are the pathoanatomy and consideration of the implant before you go into the surgery. And as I said, excessive anteversion is one which will trouble you. Whenever you do a subtrochanteric shortening, you have an option to derotate the proximal fragment that allows you to reduce the hip joint and get a stable hip. So as far as soft tissue is concerned, whenever you're doing a Cro 3, Cro 4, first step of surgery would be an adductor tenotomy. Without doing an adductor tenotomy and be prepared for earlier psoas release, don't venture the surgery, because the reduction will be extremely difficult, because adductors are very tight, sciatic nerve posteriorly also very tight. And avoid excessive lengthening. You can lengthen only 2 to 4 centimeters without osteotomy. If you try anything beyond that, as I said, sciatic nerve palsy is very, very common. And consider, in case if you have an option, intraoperative nerve monitoring to check whether the sciatic nerve is working. So these are some consideration in the soft tissue which you have to plan and execute on table. And these some cases which I'll show you like this. This is a Cro 2 or Cro 3 type. The acetabulum is shallow and you have enough medial bone. In this case, the femoral head also is good. We can ream the acetabulum, and supralaterally, whatever the unsupported area is there, you can use a femoral head as a bone graft and fix it there. Always make sure when you're doing a dysplastic hip, the cup, if instead of having 45, I'll still put into 50 so that there's no dislocation. excessive anteverted proximal fragment, I derotate, your stem should be in little retroversion and your bone graft has been fixed. This is done almost 15 years back. And this was a technique. And today, if I have to do, I'll use a trabecular metal support posterior superiorly. This is a classical example. As I said, subtrochanteric shortening technique is very, very important when you're doing a dysplastic hip. That's how we plan in CRO 3 and CRO 4. You prepare the medullary canal, prepare the metaphyseal piece, do an osteotomy, put the fragment, put the pentaphyseal, the femoral component, reduce the hip joint, and whatever the overlap segment is there, that you have to shorten. The overlapping segment you have to shorten. You can excise the fragment or keep that fragment as a bone graft and wire it. And these are some of the few cases. The first case I've already shown. This is a post-operative, some femoral osteotomy has been done. Now CRO 4, the femur is articulating with the ilium. It is CRO 4. This case, the other case is again CRO 4 in a 52-year-old female patient who has come now for the surgery. The lower two are the young girls. The first one is 22 years old girl with CRO 4 dysplastic hip, has come for a hip reconstruction. And the last one is an 18-year-old girl with a CRO 4 dysplastic hip. And if you see, the head is completely anteverted and it is a small ball there. So subtrochanteric osteotomy is a very, very important technique which you have to learn for a dysplastic hip. This is a small video how you perform a subtrochanteric osteotomy. And on the left is the head end side, that's a foot end side. And this is a posterolateral approach. And so once we have done gluteus maximus is released. And usually in these cases, we always release the Gmax attachment to the femur and make sure you don't have bleeding at that point. You catch hold of the bleeder. And the entire proximal femur is exposed here. And that's how it is done. Once we are exposed, you mark the subtrochanteric area 2 or 3 centimeters below the subtrochanteric zone and then do a osteotomy. And the amount of bone to be removed preoperative if at all you have planned. That's a mark there. So if you're doing a subtrochanteric osteotomy, exposure of the acetabulum makes very, very easy. Once you have done an osteotomy, the proximal fragment goes anteriorly, the distal fragment comes posteriorly, your acetabulum is completely exposed. And this is a situation, easily you can prepare the acetabulum implant. Once you have done your acetabulum preparation, then prepare your proximal metaphysis. That's a metaphysis you have prepared. You put a metaphyseal component and then put your trial femoral component head in place and reduce the joint. Once you have reduced the joint, you can see the overlap area, how much is the overlap, and that overlapping segment has to be osteotomized. So that's the shaft of the femur. So we have marked there. So prophylactic wire distally, because when you ream, you should not have the distal shaft to split in a vertical fashion. So you put a prophylactic wire and then do a shortening osteotomy. Once you have done it, then put your trial femoral component into the distal fragment. Make sure your rotations are correct. And check your medial and vertical offsets. And check your anteversion. If you want to derotate or reduce the anteversion, you can change in these processes. I've just little fast forwarded for the sake of time, and then you reduce the hip joint. So once you reduce the hip joint, check for movement. Also digitally feel your sciatic nerve, whether it's excessively tight or not. So once you are through, You can take off the implant, trial implant, put the metaphyseal component in place. So once you have done it, once you have reduced the osteotomy, put your actual implant in place. So then you prophylactically wire it, both proximally and distally, near the osteotomy. And then whatever the fragment what we have removed, you keep it as a bone graft and fix it up there. And then reduce the joint. Once you reduce the joint, final tightening of the wire. So hip joint is reduced. So this was a short video of subtrochanteric shortening osteotomy, which everybody has to learn. So these are the examples of some of the cases where we have done. This is a 52-year-old patient with a dysplastic hip. She is walking all these years, and 52, she wants to have a hip surgery. And if you see, there's a pseudoacetabulum formed in the ilium, and she has been walking with this. Here, what we have done is the native acetabulum, the anatomical location where we have put the cup. We had a good bone support here. We didn't have to use any augments here. Our cup placement was good enough and good bone support was there. We had to do a subtrochanteric shortening osteotomy. This is a fully coated stem. We have used a fully coated subtrochanteric osteotomy, and we have reamed the medullary canal and put the stem and reduced the thing. As I said, the metaphyseal flare is very, very small in a dysplastic hip. And if you try to put a regular stem, you may have to do a controlled vertical osteotomy on the proximal fragment also. Otherwise, the femoral component will not be seating there. So we have done a controlled vertical osteotomy of the proximal fragment, subtrochanteric shortening, derotation of the proximal fragment, and distal fixation stem. This girl, again, similar technique we have used, 22 years old girl, Crow 4 dysplastic hip, subtrochanteric shortening. On the acetabulum side, we didn't use the bone graft or the trabecular metal support because the cup had a good support, healthy bone there. Again, we have used a multi-hole cup. If you see, if you are having any doubt whether the screws are inadequate, you can put one of screws in a different direction, especially the Ishks you can put. And subtrochanteric shortening, derotation of the proximal fragment, and vertical control osteotomy of the metaphyseal fragment we have used. Today, if I have to do, I would have used a SROM prosthesis. This is done few years back. That time SROM was not there. Now if I have a chance, I will always use a SROM prosthesis. Another patient, adult patient, 35 years old male patient, has undergone some surgery, osteotomy around the proximal femur. We don't know the exact history. Now he comes with a situation like this, Crow 4. Again, we put the cup into an anatomical location, multi-hole cup, screws in multiple locations to have a good fixation, subtrochanteric shortening. Whatever the bone shortening we have done, we have stacked it around the osteotomy sites to get a good bone healing. This is the last case, 18 years old girl, dysplastia, Crow 4 type dysplasia, excessively anteverted femur. Again, on the acetabulum side, very shallow acetabulum, supralaterally no support in this case. We planned for an surgeries in same way which I was mentioning. We put the cup, supralaterally support was not there. Trabecular metal support we have used here, supralaterally to prevent the cup toggling away. Multi-hole cup, screws in multiple location, and ceramic on poly. Again, a fully coated stem, subtrochanteric shortening and derotating the proximal fragment. That's a way to go in Crow 3 and Crow 4 surgeries. And this is how you put your cup support, trabecular metal support. Whenever you don't have support supralaterally, keep a trabecular metal buttress fly fragment, which is called buttress fly. You can put there Previously, we used to put bone graft, but we realized over the period of years, the bone graft gets absorbed. Here, we're using a trabecular metal support to give a support to the cup. So if you see the long-term study in these cases, the long-term survival is very, very good. 20-year survival, almost in CRO 1 is 72% survival. In CRO 3 and CRO 4, maybe a little less, but these are old studies. But today's technique, definitely you can give 70 to 75% good results in a patient for 20 years in a young patients if you do a surgery. There are multiple studies showing that when you accept a high hip center also, they're able to give 97 to 100% survivorship. High hip center means when your center of hip moved 3 to 3.5 centimeters up from the teardrop. That is where we calculate. If it's more than 3 centimeters, then we call it as high hip centers. In type 2 or type 3, we can accept high hip centers, but these are also given good results in long-term studies for a dysplastic hip. So if you see outcome of subtrochanteric shortening osteotomy, again, very less number of non-unions. If you see the results, it's excellent results, subtrochanteric shortening and bone grafting, using that osteotomized bone, stacking it around the osteotomy site and fixing it, gives a good to excellent result. So you need not worry about the non-unions if your fixation is good. So last case, if you see this case, this is again a dysplastic, unilateral dysplastic hip. The surgeon has not really understood the concept of dysplastic hip. He thought it's like a regular total hip replacement. He didn't do an adductor tenotomy. If you see this surgeon has executed this surgery. I'll show this is a CT, what the patient had before surgery, and that's how the patient has come to us after the surgery. The surgeon has failed to do an adductor tenotomy, failed to adjust the soft tissue problem. Again, the cup was vertical. He has used a sector hole cup. He should have used a multi-hole cup and fixed it inferiorly also. He has only put 3 screws superiorly. The whole cup has no support supralaterally. He has not used a trabecular metal support. The whole cup has toggled up. Because the forces are so high, the cup toggles up or becomes loose there. Again, the stem anteversion is not corrected. So this patient had to undergo a surgery 3 days after the primary surgery. So the whole thing had to be repeated. And that's the reason dysplastic hip is a different ball game. You need to have a different mindset when you go inside the surgery. Planning, implants, and execution is very, very important. Without that, definitely you will have a disaster like this. The key take-home point is anatomical cup placement desirable whenever possible. Whenever the acetabulum reaming you're doing, be very, very careful when you ream. Always feel the anterior wall, posterior wall, and the medial wall. Don't ream excessively. Subtrochanteric shortening as a standard is a standard when you have doing a CRO 3 and CRO 4. As I said, proper planning with appropriate implant, absolutely essential whenever you're doing a surgery on a dysplastic hip. Thank you for patiently listening. Any questions is there? We can take it up now.
Yeah, thank you, Dr. J.V. Srinivasan. Already there are some questions there in the chat box. Can you access the chat box,
Yeah.
J.V.?
Yes, sir. So 1 minute.
So the first question is on dual mobility.
Yeah. Get me, sir. Give me a second, sir. Yeah. Yes, sir. So dual mobility, yes. Dual mobility is a fantastic tool, sir. Because these cases were done when the dual mobility was not there. But today's, when you have a dual mobility technology, if you can put a cup in a good position and definitely anteversion is correct, dual mobility is an excellent tool in dysplastic hips. So another same question, bilobed cups is, I think so it is same thing. And yeah, one more question is it very essential to use a diaphyseal fixing stem? Yes, if you have a diaphyseal fixing stem, you will be assured of the osteotomy healing. But if when you have which does not hold on, especially the SROM, you have a fixation on the metaphysis with a metaphyseal component and you put a stem inside. Sometimes the fixation is not good in the diaphysis. You may have to supplement with a plate, especially when you use a SROM. I'm sure Dhanasekara Raja has done enough SROMs. He will tell the distal fixation sometimes is not adequate. In that cases, we may have to add a derotation plate to hold on till the osteotomy heals.
Yeah, it's not mandatory to get diaphyseal fixation, especially if these are all inpatient. Better to preserve the diaphysis for the future revision. Better to get your fixation in the metaphysis. And the SROM, if it is the distal fixation is good enough, we can leave it alone, or we can add a small plate, as Dr. Srinivasan has said. It will stabilize the osteotomy site. But better to have a metaphyseal fixation.
One more question is adductor tenotomy as a standard in dysplasia. Yeah. So dysplastic hip, especially CRO 3 and CRO 4, when you are trying to reduce, we don't know what are the muscle forces. Adductor tenotomy is definitely first step whenever we're doing a CRO 3 and CRO 4.
Dr. Pachore, can you hear us, or can we hear you?
He is in the wrong link.
Yeah. Correct. Anyway, anything else, Dr. Dhanasekara, you want to add?
No, it was an excellent presentation. As we know, we classify dysplastic hip into CRO. Type 1 is like a standard hip replacement. 2 and 3, we put the cup wherever the best bone is. And type 4, definitely we need to do a subtrochanteric shortening osteotomy. So Dr. JV has stressed all these important points, and it has to be done with the proper training, not for everybody. The difficult cases, and he showed some cases where it has been not managed appropriately. So we should follow the principles and try to achieve good results. Thank you, Dr. Srinivasan.
Thank you. Thank you.
Yeah, somebody's asked about derotation plate. I think Dr. Dhanasekara has just already answered. Can you just see that question?
Yes,
Yeah,
yes,
Dhanasekara has already answered. The derotation plate is not mandatory. If your fixation is good distally and proximally, you don't require, unless you are not sure about your fixation. Usually, because when you do a subtrochanteric shortening, the forces are so high at the osteotomy shortening site, usually it gets compressed. But if you feel the forces are inadequate and the fixation of the implant is inadequate, you can always add a derotation plate. No harm in that.
Sometimes you have a metaphysio-diaphyseal mismatch. For the SRAM system, there are only 2 size sleeves which you can match with a particular stem. So if you are using 8 millimeter stem, there are only 2 sizes. So similarly, if you use a 10 millimeter stem, there are only 2 sizes of metaphyseal sleeves. Once you use the metaphyseal sleeve, the size of the stem is a limiting factor. So sometimes you have a mismatch between metaphysis and diaphysis. Metaphysis fixation will be adequate. Diaphysis, there won't be adequate fixation. These are situations where we use a additional plate for axial and rotational stability.
The weight bearing protocol changes with the osteotomy part. What would be the suggestion for that, Dr. Raja?
I think we start with toe touch weight bearing that will allow compression at the osteotomy site. Probably at 4 to 6 weeks time, we allow full weight bearing.
Yeah, partial weight bearing till 6 weeks and then go for full weight bearing walking.
And as you mentioned, it is always good to use that bone graft which comes from the osteotomy.
Yes. You feel secure that you have bone graft at the osteotomy site.
Because there is a bow at the proximal, sometimes the osteotomy does not match. So there may be some gap which we try to fill it up with the whatever osteotomy bone we have removed. So that will help in bridging the gap.
Okay, I think if there are no more questions, Dr. Dhanasekara Raja, can you just please conclude? And the next session is going to be on 14th of September. So please remember the date. It's going to be 14th of September. We'll come up with 2 more senior speakers on 2 different topics. Dr. Raja, over to you.
So I request all the FNB students, please inform your friends. The new batch has joined this year. Please inform all the new students to join the WhatsApp group and join the teaching program. It's a very useful program. So I also request all the Ishks members to join the program in future. As we said, the next program will be on September 14th. And I thank the speakers, Dr. Parag and Dr. J.V. Srinivasan, for sparing their time. And thank you, Ishk, for giving the platform for our educational program. And thank you, our president, for staying over the entire program.
As we discussed, Dr. Dhanasekara, last time, probably we may encourage some case presentation from the students, probably in the subsequent lectures. We have 1.5 hours, so we can spare about 10-15 minutes, and we can have 1 or 2 case presentations from the delegates, so and discuss some difficult case. Planning in the future, will come out with that, so that you also get a chance to present your cases and difficult, and we can discuss that. So this also has been worked out, and we are thinking of getting you participated as a case presentations and get a platform also along with these lectures what we are already having. So we'll come up with that, but please send the message, and we look forward to see you the next month on 14th of September. Thank you, JV. Thank you, Dr. Parag and Dr. Indrajit Sardar. Thank you very much.
Thank you.
Thank you. Very good.
Session.
Yeah. Okay, fine. Thank you. Thank you, Dhanasekara.
Thank you.
Yeah, fine.